Forward Media. This is Healthcare Musings. I'm your host, Dr. Hashem Hasabala. Welcome to Healthcare Musings, everybody. Happy to have you with me. I am delighted to have on the show Mr. Kenneth Kaufman. He is a managing director of Kaufman Hall. Kaufman Hall is the go-to place if you want to know the ins and outs and the intricacies of the hospital business. And I've been working as a partner with hospitals for more than a decade now in my role as Associate Regional Medical Director and Sound Physicians. We partner with hospitals to provide critical care services. So I've really gotten an inside look in what it's like to run a hospital. As a physician advisor, I know I'm very intimately involved with revenue cycle, and I kind of understand kind of where the regulations and all the reimbursements, and then and as an appeal writer, I'm in the fight against payers when they deny either medical necessity claims or diagnosis claims after discharge. And so when Mr. Kaufman reached out to me and we connected on Substack, I had to have him on the show so that we can kind of get a sense of the reality of the hospital business. One of a healthcare CEO told me once, the last thing I would want to be is a hospital CEO. Which I was taken aback by that. I was like, wow, because, I look at I've dealt with a lot of hospital presidents and CEOs. They're great people, and it looks like it's a great job. And there are very few businesses that are 24/7 all the time. My son and I were driving. We live near a hospital. My son and I were driving, and I told him it's open right now, and it's very few businesses are open 24/7, and so there are unique challenges in running a hospital and keeping its doors open, and so very few people are better versed to help us understand that business than Mr. Kaufman. So welcome to the show, sir.
Thank you very much. Thank you for the invitation. Delighted.
It's great to have you. So kind of give us a sense of there's this perception that, oh my God, look at the gleaming glass and the brand new towers that they're building and all these things, and all the hospital administrators are, and there are for-profit hospital systems and nonprofit hospital systems where the administrators and the CEOs, they're making millions. I saw on Theo Von, a recent episode of Theo Von, where they were talking about the nurses' strike in New York, and then they flashed up the pictures of the CEOs and their salaries, right? So there's this perception that, even among my family, they're like, oh my God, hospitals and blah, 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 and they're just and then they remember the bills. Even me, like when I went to the emergency room, I was sick several years ago. I mean, it was tens of thousands of dollars that the bill that I got for the few hour emergency room stay. So I know it's different. I kind of give us a sense of what it's really like to run a hospital.
Well, it's an incredibly hard job. It's been getting harder, and I think most hospital executives think that the next couple of years may be the hardest, and I think they're really taken back by that because it's already so difficult. The tax bill that was passed by the Trump administration, I think, as everybody knows, the deal that was made was that there would be some kind of federal budget offset in order to allow the tax bill to go forward, and the offset wound up being mostly a tax on the federal payment of health care, and the likelihood that there'll be a reduction of Medicaid patients in the country by maybe some 12 or 13 million. In addition, we've had the ACA subsidy issue, which is still ongoing. That hasn't been settled at all. And when CMS issued its statistics about a week ago, it said about 800,000 less people had signed up in January of 26 than signed up in January of 25. So the ACA bill was really a very positive thing for hospitals. Up until that point, we were going along with about 13% of of the nation uninsured, and the ACA reduced that to 8%. And now it looks like we'll be heading back up towards 13%. And I think your listening audience certainly knows that under the federal law, hospitals are obligated to treat everybody who finds their way to the hospital emergency room or to the hospital in any way. And you treat them first and find out if they have insurance second. So this is all problematic. Just make the comment that COVID was extremely difficult for hospitals. We had a period of time in 2022 where most of the hospitals in the United States were losing money because of the COVID situation. And some of the hospitals have recovered since then, but many of them have not. So that's our status. About our statistics show at Kaufman Hall that about 43% of the hospitals in the United States are still losing money. And that's before we see the reductions in Medicaid and the reductions in ACA and other things. So
So that's very
that's
hard for a lot of
sort
people
of
to
sort of the
believe.
lay of the land. Yeah.
Oh, so I think there was a little bit of a lag. So you said 43% of hospitals are still losing money. How is that possible? I think a lot of people have a hard time believing that.
Well, it's possible because of two things that the revenue ecosystem for many hospitals just doesn't work. When you think about how hospitals get paid, they have a portion of Medicare, they have a portion of Medicaid, they have a portion of commercial, they have a portion of 340B, they have special outpatient revenue base. It's a puzzle. It's not like it's not like a business. I think most people say, well, it's a business, but hospitals don't get paid like a business. I mean, if you went out to California and you interviewed Tim Cook and you said, how does Apple get paid? He said, well, we charge about $1,100 a phone and we plan on selling 300, we plan on selling 7 million phones and multiply 1,100 by 7 million and you've got a pretty good idea what's going on. It doesn't work that way for hospitals at all. And those reimbursement structures are shifting all the time, even across a month or across a couple of months. And hospitals have to patch that revenue ecosystem together. And some hospitals, if they have good market conditions, they can figure out how to make it work. But if you've got mediocre market conditions or poor market conditions, then you're just running behind all the time.
And when you say market conditions, do you mean payer mix, like the?
I mean payer mix, I mean clinical mix, I mean quality of doctors, I mean, the kinds of patients that come, what you're able to deliver. You've seen one hospital, and just you can just take a large metropolitan market and look across that market, and you'll see so many different kinds of hospitals that have created different kinds of markets for themselves.
Can a hospital run on government healthcare only? Like
No,
if it's 100% Medicare, Medicaid?
not no, no,
No,
no.
N-
Those
no.
all
So
all of those hospitals that are in that situation lose money, and they don't have sufficient cash flow to support the hospital going forward.
and I'm like, just to go back, the hospital is such an important part of the community. It's an employer. It was during you mentioned the COVID pandemic. I mean, they were there to care for people who were literally dying. I mean, I was clinical. We worked at in the pandemic, and it was just one after another coming into. And many of them are
People
dying
people
or trying to die.
people
How is
forget.
it?
Yeah, go ahead.
I'm saying, how could it be that they can just let I mean, how is it that the hospital would lose money on just government health on government reimbursement?
Well, because these programs were set up with in the 60s as part of the Great Society to provide a social and safety net. approach, and to a great extent, many of the legislators who were part of that never expected all of this to be as expensive as it would become, and there's a great reluctance on the part of the legislative and executive branch to fund, to fund healthcare adequately, to consistent with the policy decisions that were made there. And there's no doubt that if you look at the federal government at this point and you ask them to go back and reconsider Medicare and Medicaid, you probably couldn't get that passed in today's Congress.
I see. And so then the hospital bill that people get, you stay in a week in the ICU or a month in the ICU, and you're talking in the millions or tens of millions. Is that just funny money? Is that what? That's again, that's a perception that people when they
Well,
get even me. I mean, 10, 15 grand for an
yeah,
ER visit, and then you're like, how could the hospital be losing money?
yeah. Well, hospitals don't get paid what that charge is. Most people, very few people pay out of pocket. So, and if they do pay out of pocket, they're definitely not paying that bill. Medicare pays a portion, and Medicaid pays a portion, and all of the commercial insurances are negotiated. So, if you have commercial insurance and you get a bill for $20,000, then what the hospitals get is going to get paid is what they previously negotiated with the insurer, which will not be $20,000. And if there's so the insurance company may pay, $9,000 of that, and then there might be a copay of 2,000, and that's what the hospital gets. So they billed 20,000, but they only wind up getting 11,000.
I see. I see. But and the main cost to drivers in a hospital is still labor, right? I mean, is still all of the
Oh,
people who
it's all these things. It is labor is probably 45 to 50% of the overall cost in most hospitals. Those hospitals that are run very tightly might be in the 40 to 45%, but the other hospitals that are not run quite as tightly are in the 50s for sure. But the inflationary condition of supplies and other expenses, and of course pharmaceuticals has been running much higher than labor over the last 5 to 6 years.
Oh, really? The cost of pharmaceuticals.
Yeah, the
Mm.
fastest growing expense to hospitals in the country is pharmaceuticals right now.
Oh, wow. I mean, puts it into perspective when me as a treating clinician, and I write for a drug, and either they say no, or it's not on formulary, or you can't do it, or yeah, and it's very frustrating from my end. I think this is what is best for my patient, and a lot of clinicians don't understand the kind of the cost pressure on the other end of the spectrum.
Yeah, well, the only way to get expenses down is often to get physician agreement around those, about procedures and how procedures are done, and the most common example is if you've got 20 orthopedists doing hips in your hospital, can you get them to use all the same hip? And if hospitals can do that, then they can lower the cost of the operation. But very often, doctors are not amenable to those kinds of agreements. So it's a you know it's a tough business.
Yeah. And when hospital systems employ physicians, is it still the case that there is a subsidy inherent, meaning that they're losing money on
Yes.
the physician's salary?
Yes, they are. Hospitals employ many, many physicians across the country. That started in 2008 when we had the financial crisis, and many physicians in private practice just couldn't see how they could continue to do that, so they started signing up with hospitals. And it's continued over the last 17 to 18 years. But one of the things that's happened is there always was some kind of subsidy, but that subsidy has gone up increasingly. Um, over the period, and especially over the last 5 to 6 years. And many hospitals around the country lose a fair amount of money on their employed physician groups.
So why did they do it? Is it control?
Well,
Is it
well, the well the way
market?
the way it used to work is that it is that you could lose money on actually employing the physician, but if the referral situation was right, then it could be it could be an acceptable strategy. So if you had employed physicians, and some of those physicians were referring you, your most profitable services, then you were making those subsidies back on the work that you were actually doing in the hospital. So that's worked for, that continues to work for some hospitals, but for other hospitals, it just doesn't really work anymore. You sort of had a breakdown on the referrals, or you could have competition, and the kind of work that those employed doctors were referring to you is not going to you anymore. Now it's going somewhere else, and so if all of that gets out of balance, then what you're really just doing is losing money on the employed doctors. But
Well,
it's
isn't there inherent control over what if I'm employed by a hospital system? This is what happened to me in private practice. All of my referring doctors got acquired by hospitals, and the hospitals had their own specialty groups. So they
right.
would refer in. So I mean, isn't there a pressure if I am a primary care, or if I'm a pulmonary, I'm pulmonary critical care. So if I'm pulmonary critical care and I'm owned by I'm employed, not owned, employed by a hospital system, I think I'm going to get pressure to refer to my colleague, my cardiology colleague, who is also employed by the
Well,
same
yeah,
system, right?
yeah, yeah. So I mean, that's really, I think the right vocabulary there is creating an integrated system of care. So I think you have to choose your words carefully as to how this is being done. But it's not. The level of success in creating that integration is really on a hospital by hospital basis, and some hospitals have probably made a lot of progress on creating that integrated network over the last 20 years, and other hospitals have tried, but been much less successful.
I see. So, and this parity payment parity between hospital outpatient, or there used to be a difference in payment between a hospital outpatient department and a regular outpatient department, and that's going away, and that seems to be the
Well, so
hospital
that's just
executives I speak to, it seems to
yeah.
be that's a huge threat. Tell me about
So
that.
that's the site neutrality. And that when outpatient rates went in, the hospital industry convinced the government that they were operating out of much more expensive locations than just pure ambulatory care. And so if you were doing a ambulatory surgical procedure in a hospital outpatient, then the hospital would get paid more than the ambulatory surgery center across town. And the term for that is site neutrality. Um, and that site neutrality has been under attack for quite some time. And if site neutrality is removed, then hospitals will lose a very significant amount of reimbursement.
So is their point made then, because it does cost more for the hospital to keep open an outpatient surgery center? Does it cost more, or they're
Well,
saying it costs more?
it does, because the setting is in the hospital, and the hospital is open 24/7. And so there are costs associated with keeping your ambulatory services open within the hospital and operating them, that that a chain of surgery centers doesn't have those same expenses. For a surgery center, they probably open at 7 in the morning, and at 6 o'clock at night they're closed, and there's nobody there from 6 to 7 in the morning. But that's not that's not how it works at hospitals. This has been a very contentious issue. There's a lot of people in Congress who take the same position that you just did in your question, and we're just not 100% um, to see where it's going to go. But but Congress needs to be very careful because the reimbursement and revenue situation within the hospital, I call it a revenue ecosystem, and 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 Congress is now sort of in the process of pulling apart that ecosystem. And I don't think they fully understand exactly what they're doing. So there's some hospitals in the country who will be able to survive um, that dismantling of that ecosystem, but there are many hospitals across the United States that will not be able. They'll just get to the point where there's no way to replace those dollars. There's simply no way to replace those dollars, at which point they have to start cutting services. They have to make change in the clinical activities that they offer, and the community is going to suffer.
Oh, wow. And so is that settled, or are they still fighting about it? Or I mean, is the site
No, I
neutrality
think
thing?
100%. I think they're still fighting about it. I don't think this is settled. I might be wrong about that. Maybe I haven't kept up quite enough, but I don't. I still think it's under consideration.
So then, does it behoove hospitals to just acquire ambulatory surgery centers,
Well,
or open their own?
yeah, well, yeah, a lot of hospitals have been pursuing that strategy for years, and many hospitals across the country are operating their own ambulatory surgery centers on an outpatient basis. In other words, they're not located in the hospital, but
Right.
there's a lot of ambulatory surgery that goes on within the hospital walls of this country.
Well, that's what someone told me, that the hospitals pay for everything that they do by the outpatient surgeries that they do. So they maybe break even or lose money on all the inpatients that come in, but they make money on the outpatient, the hips, the knees, the gallbladders, the
It is, it is,
the
it
drainage
is.
procedures, all those things. Is that still the case?
It is one of the remaining profitable services available to many hospitals across the country.
Is outpatient surgery?
Yes.
Yeah. I mean, is there, and then there's this whole thing about the 340B. And there's a huge there's all what is that, and what's the contention there?
340B is a program that's been around for a while where hospitals are able to uh, um, basically uh, purchase specialty drugs and then resell them within their organization, uh, and and the program has allowed hospitals to to make a profit on that process. Um, Many hospitals have been aggressively using 340B for a long time, and it's another. As I said, there's this ecosystem of revenue, and 340B is another part of that ecosystem. So, most hospitals in the country are not making money on Medicare. They're not making money on Medicaid. And so, site neutrality and 340B help make up for the fact that the reimbursement in Medicaid and Medicare is just not high enough to take care of patients at the level that is required in our country right now.
Yeah, I think I saw a reference. Becker's referred to your report that it costs that they broke down costs on average in every state, and it's well north of $3,000 a day for to keep the doors open. Is that about right? I think they referenced your
No, I
report.
don't remember. I don't know if I picked that up, but
Okay, yeah, because Becker's had it. Maybe I'll link it in the
yeah.
show notes.
Mhm. Yeah.
At least 3,000 plus per day
Mhm.
to run a hospital.
Mhm.
That's just the cost, just to run a hospital. To begin, it's a 24/7 business. So what, where I think what as a provider, I hate that word, and there's really not, as a provider. the fingers always pointed at us as you're the cost, you're the problem, you are what's costing so much money. Look at the beautiful buildings and the nice cars that the doctors are driving. It's your fault. My sense is that the proportion of healthcare spending that is paid to the provider, hospitals and doctors, is minuscule compared to everything else. Is that what you're seeing?
Oh, no, I don't think you would say minuscule.
Well, I mean, in the healthcare dollar, it's not like 50% or even
No,
even
no,
10%.
no, hospitals and doctors make up a large portion of the total spend in the United States. I don't know what that
I was
we don't know what that breakdown is right now, but, we're back at about 18% of GNP, and I would guess that hospitals and doctors are at least 50% of that 18%.
50%. I've heard
Yeah.
4%.
No, 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 that couldn't be
Re-
right.
Really?
Yeah.
I'm surprised. Wow. What is your sense then of where how this is not sustainable, obviously. Where do we go from here?
Well, we're just heading out on a journey here, and we don't really know what that journey is going to look like. And so, as we don't 100% know yet how these new rules will be applied, and so we don't know how many Medicaid patients will lose. Um, but but as we lose those Medicaid patients, it's very possible that they will simply become uninsured, and then we'll deal with the rising levels of uninsured and uncompensated care. And there's a lot of speculation about, okay, what are the ramifications of that? And many commentators in the industry believe that the safety net hospitals in the urban area and the rural hospitals will be the first hospitals to truly suffer from that situation. So, you've got group of safety net hospitals in every metropolitan area. Um, and um, how many of them can survive in this situation when they're barely surviving at this point?
Is there do you is there a significant amount of fraud in there's always fraud in the healthcare system. Are hospitals afflicted or perpetrators of this fraud? Are there, all the headlines of this and that, and
There's fraud in every industry. There's fraud in every industry in America, one way or the other. But I don't think that the 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 hospital industry is suffers from any greater level of fraud than any other industry in the United States. I don't believe that, and I think the commentary that has gone on in Congress around that over the last year and a half is seriously overdone.
oh, really? Interesting. I mean, you're painting a kind of a grim a grim picture as people who need the hospital for. I mean, what do you see it will be the hospital of the future? Will it be hospital at home with telemedicine? Will it be just an ambulatory surgery center? And if you get critically ill, then you go to the ICU where I'm going to be working. What is it? I mean, that's impossible to know for certain. What is the sense of the hospital of the future?
Well, I think it's all of those things. I think, there's the hospital at home is a developing situation. I don't think anybody really knows 100% how that's going to work out in the long run. Um, there's more and more ambulatory work because we continue as technology changes, we continue to be able to take procedures that for years and years have only been done on an inpatient basis and make them outpatient. And so for many hospitals, they're seeing less inpatient work, but they're seeing a lot more outpatient work, depending on what strategy they've employed going forward. Um, and then we have technology changes in which we're treating diseases that we were unable to treat before, and we're treating others in ways that are completely different than what we were able to do. So it's all you know it's a very complicated process, and And hospitals that are profitable and that have good capital capacity will probably be able to adjust to the new world, and those hospitals that are already struggling will have a much harder time adjusting.
I mean, but that's it's. I think it's a tragedy whenever a hospital closes, right?
Well, yeah, I think that's an overstatement. I mean,
How so?
ba-
Tell me.
because we operate in a capitalistic economy. That's what America is. I read a note the other day where one economist commented that the strongest level of capitalism in the world is in the United States, and with the tech development in AI, that's even getting greater and greater. So hospitals operate in that same milieu. You can't say that they're excluded from that milieu. So very often, in a capitalist society, those organizations that are extremely well run and where great strategic decisions are made, and they're properly financed, those organizations become successful, and then they become more successful. And then you have the losers, and some level of losers just have to go out of business, and that's how a capitalist economy works. And so for us, we have when hospitals go out of business, some hospitals, when they go out of business, it's really truly a community tragedy. But in other cases, when hospitals go out, they're just not organizations that are adding any value to the healthcare community.
Really? Because I mean, if you're used to going 5 minutes to the hospital for whatever you need, your outpatient physician, and now you have to go, especially in a rural area, you have to go now 50 miles away to get care. I mean, isn't that a problem?
Well,
It's maybe not in the
In in
in
in
my
a in a
area.
in a rural area, you have to talk a rural area winds up with a very different discussion than in suburban and metropolitan areas. So, in suburban and metropolitan areas, if a hospital goes out of business and, you have to go 20 minutes now instead of, 10, then you go 20 minutes, or you have to drive downtown when you didn't use to drive downtown, then you drive downtown. But by and large, in those situations, that will be offset by you're probably getting better care than what you were getting in a hospital that was financially distressed. In the rural areas, you run the risk of what, they call healthcare deserts,
Hmm.
where the first healthcare desert that we've really experienced in rural areas is obstetrical services, because a lot of financially struggling rural hospitals can't afford to keep their obstetrical practice open. And so the board and the management team wind up with a very difficult decision. Do we keep the rest of the hospital open and close obstetrics, or do we keep obstetrics open and run the risk that we'll have to close the entire hospital because our financial condition will become so distressed? And as a result, there are a lot of families that are driving quite far for obstetrical care now around the country. It's not a good situation, but honestly, nobody has really come up with a solution.
Wow. So even that one service line could tank the entire hospital in
Yeah,
a rural area.
absolutely. Yeah,
Really?
because of the regulatory factors of, if you're only like a 60-bed hospital and you're only doing 150 deliveries a year, there's a checklist, a state mandated and federal checklist of all the things you have to have in order to have an obstetrics. And so the costs become very significant, but they're not supported by a large enough practice. In other words, I can't spread the cost of 150 deliveries. I can only spread those costs across 400 deliveries, but there's never any chance in that rural area I'll have 400 deliveries. So those costs then become expenses that are not covered by revenue in any way.
Oh, wow. Doesn't the system just need more money? Don't we just have to pay more taxes? Uh, you know what I mean? Don't we just have to? We just we if we want if we want Medicare to pay at the rates that they should, and as a physician, I'm the Medicare rates that we get are woefully under what it costs me to keep my. That's why that's why we rail against these reimbursement cuts. It's not because we're greedy and we want to get another car. It's because you just like you said, on government reimbursement, Medicare, Medicaid, I can't keep my practice open. I can't. All the costs go up and the revenue keeps going down, and that's what it was when I was in private practice.
I think I'd answer your question that we've avoided having a policy discussion in the United States around this for years and years, and eventually we are going to have that policy discussion because everybody pretty much winds up using Medicare. And so, the country and the federal government has to make a decision of whether they're going to properly fund it going forward so that people can get the level of care they expect. They paid taxes all those years and they expect to get a quality product. And it's not entirely clear, that in every situation, if you're using Medicare, that you're going to get the product you expected when you paid those taxes.
Wow. Well, there's a lot of food for thought. I think I'm glad I had you because I wanted you I wanted you to really give the audience the sense of how hard it is to run a hospital, and it's not as simple as it seems, and it's a very difficult business. Do you agree that the last job you'd want to have is be a hospital CEO? Is that
No, I don't really agree with that. I think that that hospital CEOs by and large do a fantastic job. I know thousands of them, and I've worked for them for over a very long time and seen their level of dedication, their level of commitment. They get into this, not for the reasons. I mean, sure, they enjoy getting paid, and and they enjoy having a job that has a lot of credibility to it, but they do it mostly because they want to be of help, and most of them do that, and I think a lot of hospital executives still feel that they're getting, that love, that they got into this for a particular reason and they're still getting a lot out of it, and they are making a big difference in their community and helping patients every day. So I think it's still a very high quality job. It's just the problem is when you're asked to do a job and you don't feel like you have the resources to do that job every day, then that's when burnout begins to settle in. And we certainly have seen, just like there's a lot of doctor burnout. There's a lot of hospital executive burn. I've certainly seen a number of my good colleagues on the hospital CEO side over the last 4 or 5 years retire much earlier than anybody expected they would retire.
just because of the pressures of running a hospital?
Yeah,
Wow.
just because I just can't do this anymore, I mean, that's what they're saying. I've done this as much as I can. I just can't do it anymore.
Wow. Wow. Well, Mr. Kenneth Kaufman, it's been a pleasure having you. Thank you for your insights and your understanding, and to give the audience and myself a sense of what it's like to run a hospital. It's great to have you. Have a wonderful day and weekend.
Thank you very much. Thanks for the invitation and asking me on. I enjoyed it. Thank you.
Me too. Thanks so much. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.